So early on, we were able to demonstrate using actually an aptamer, which is what David just pointed out. The aptamer was a selective way of blocking VEGF, and we were able to demonstrate in some clinical trials the ability to control diabetic retinopathy and reduce the need for laser, which was the first studies that were published back in right at the end of 2004. And then, our group, we did some work with using the particular drug in proliferative diabetic retinopathy, and also demonstrated that there was an obvious benefit in terms of the regression of diabetic retinopathy using this particular agent. So that sort of set the framework for, some of the larger studies. I mean, I think, the more recent ones that we've had here, were through the DRCR-NET, which is a group that's funded by the National Institutes of Health, the National Eye Institute, and what we were able to demonstrate in that particular trial is that if you randomized your diabetics with center involving diabetic macular edema, that you were able to, and you randomized them into a group that received the drug and immediate laser, or a group that received the drug and we delayed the laser 6 months. That at the end of the trial, when you had those two groups and you compared them to the standard treatment, which was laser, the two groups that received the drug were significantly better in terms of stability, in terms of three-line gainers, in terms of the quality of the vision, versus those individuals who received the classic laser. And what was really nice about that study is that the study demonstrated that it didn't really matter if you gave the laser immediately or you gave it later. The real benefit was receiving the drug.